Hi, good evening, and welcome to episode 11, Prevention and Treatment of Baseball Injuries Utilizing Workload and Performance Metrics, with Doctors Brandon Erickson and Peter Chalmers. Um, Happy Veterans Day to all those who have served and all those who are serving. My name is Stan Conte, and this is Nancy Flynn. Nancy Flynn, who is my partner in this venture. I hate to tell you two things. One is she is about 8 months pregnant. She doesn't look like it because her virtual background is so good. Makes it look like she's not, but she's about 8 months pregnant and deliver in January, right?
Correct. Yep.
Yep. Again, thanks to Nick Conte at Conte Sports Performance Therapy, CSPT in Scottsdale, who provide support and to be able to put this webinar on for free. For me, this is one of the topics I've always wanted to do on these webinars. In baseball world, there's a significant use of words like workload and performance without anyone defining them the same way. Today, we'll be able to get some depth into the words and definitions and how they can be used. The presenters will analyze the role of these terms in the prevention of baseball injuries that continues to increase at every level. I'm very excited for them to present and their research studies and opinions today. Our setup for the episode is slightly different than past episodes. Instead of having 3 speakers giving 3 presentations, we will have 2 speakers giving 4 presentations to each. We have gotten good feedback on the audience on the Q&A that appears to be very important to you, so we have put more time in the Q&A, breaking it up into 2 different portions. Dr. Chalmers and Dr. Erickson will present 2 talks and have a Q&A session, then proceed on the next 2, followed by another Q&A session. It's important for everyone right now to start putting questions in that you might be curious about in real time while they are presenting, so that we have questions from the audience at the first Q&A after the 2 sessions. Don't wait until the end of the presentation to put your questions in. Start putting it in the Q&A. Do not use the chat, use the Q&A. The titles of their presentations today, Brandon Erickson will be presenting on when you say workload, you guys say, and defining the inclusive terms of workload will be his first presentation. The second will be when will he get back? What to expect following some of the most common surgeries in professional baseball players. Dr. Chalmers will start the presentation off with pitching injury mechanics and defining success and return to play. A few housekeeping items. We continue to have some small issues with the survey at the end of the presentation that you must complete and pass in order to get your CEUs. Out of the nearly 1,000 participants that have earned CEUs each episode, we get about 20 or 30 who misspell their email in the survey. This is critical to put the email address in correctly. If you do not, it will not reach you. Double check your email spelling when you do the surveys for the CEU, and that'll help a lot. Many of you continue to request the ability to get episodes on demand and get CEU credits. We anticipate and have been working on putting all our episodes online on video on demand starting in January 2021. You will get an email notification when they are online. Because video on demand and the CEUs increase our costs, we are going to have to charge a minimal fee to cover our increased costs. The cost will be, I guarantee, lower than any other CEU course. We're just going to try to cover our expenses, and that's all. So it's going to be very inexpensive. The live webinars with the CEUs will continue to be free. So when we do these live seminars like today, they will continue to be free. The videos on the live webinars will also be free to view on conteperformance.com, but without CEU credits. It's also important because of BOC rules and your CEUs to stay on the live webinar for the full 2 CEUs. That's not our rule. It's the BOC requires us to monitor these, which we can tell how long you're on using Zoom. and they review those to make sure that you have spent the full 2 hours. So if there's some reason you have to leave, there's an emergency, or you have to, go somewhere for a few minutes, keep the video running. There will be no conference in December, but we will start the webinars in January and present one per month for the next 12 months. In our comments at the end of the conference, please suggest topics that you'd like to see in 2021. So let's introduce our speakers. Oh, I'm sorry. About 3-4 months ago, when I decided to work on workload and performance metrics as a topic, I do what I always do, and that is go to the literature, review the literature on that topic to see what studies are out there and what studies are not, and also who are the leading researchers in the topic group. When I did that, I continued to see 2 researchers whose names were prominent. That's Dr. Erickson and Chalmers. As you know, since we sent out we all sent you out a bibliography, we found that they have co-authored and teamed on 26 studies just related to our topic and published them since 2015. To give you some perspective on that, to publish one study in a year is considered excellent. I listed their number of studies per year, and it's pretty amazing. In 2020, and we're not even done with 2020, these guys probably publish several more before the end of the year. 5 studies. In 2019, 9 studies. In 2018, there was a 0 on there. In 2017, 7 studies. 2016, 4 studies. In 2015, 1 study. This is pretty amazing. I think in 2018, they must have been just tired of writing and had to take a little bit of a break or for whatever reason. This only accounts for the topics on this related to this episode. They've written many other non-baseball subjects as well as book chapters. It's an impressive amount for 2 orthopedic surgeons just 3 to 5 years since their residency at Rush Hospital in Chicago. So let's formally introduce them. Peter Chalmers is on faculty at University of Utah in orthopedic surgery. He obviously focuses care on sports medicine, shoulder and elbow, but also shoulder replacement. His practices include minimal invasive arthroscopy. He's the team physician for the Salt Lake City Bees, a AAA baseball team that is affiliated, I think, with the Angels, and also with the University of Utah baseball team. He is the team physician for the Utah Jazz professional basketball team. Education out of Dartmouth, dual major in biology and biophysical chemistry. Probably didn't go to a lot of frat parties with that background. Medical School of Columbia University, Rush University Medical Center for his orthopedic residency. And I want to make a side note here is that both Dr. Erickson and Dr. Chalmers did their residency at Rush University Medical Center. And I'd be remiss in not mentioning Dr. Anthony Romeo, who is a mentor and leader in that residency program and produced these 2 guys. Also, his fellowship was at Washington University in St. Louis. He's authored many, many articles. These are just some of them. And again, you'll see the bibliography where his name is prominent. He lives in Salt Lake City with his children, Elma and Lily. His wife, Anna, is an oncologist at a cancer center in Utah. Dr. Erickson is a section chief, shoulder and elbow surgery at Phelps Hospital, assistant professor at Zucker School of Medicine, Hofstra University, assistant professor at Sidney Kimmel Medical College at Thomas Jefferson University, and is the assistant team physician for the Philadelphia Phillies. He's a New Jersey native and reports to have played at the University of Notre Dame as a wide receiver. We don't have confirmation on that really yet, but he can speak to that. Medical school at Tufts University, Rush University Medical Center residency in orthopedic surgery, and did a fellowship in HSS. I want to kind of make a call out to HSS. They have an interesting fellowship program where there's a year of research attached to that residency, and that produced A lot of the research stuff that Dr. Erickson has done also, just to mention Dr. Christopher Camp, who did that fellowship just before Dr. Erickson. You know, again, too many articles and publications to mention. Brandon and his wife, Carrie, live in Westchester County, New York. And this is a picture of them in Japan. This is where I first met Brandon when we went over to speak to in Tokyo a couple of years ago. Again, if you didn't get the bibliography, we'll try to get it to you. We sent it out a couple of days ago, but just to give you the enormous amount that these guys have done in literally 5 years, these are all, this is kind of amazing. So I also want to thank Brandon and Peter for donating their time and expertise to make the webinar possible and to keep the costs down on being able to give free CEUs. Okay, so our first presenter will be Dr. Chalmers. So I'm going to get off here and we'll go with that.
All right, can you guys hear me?
Yep, you're all set.
All right, so, well, thank you so much, Stan, for having us. I can't tell you how much I appreciate the invitation to talk about something that's obviously a subject of great interest to me. And I gotta be honest with you that this is, what you're seeing here is the result of a long collaboration with me and Brandon. Brandon's been an incredible research collaborator, and I'm sure you'll look forward to seeing all of his insights. And we're going to start out kind of at the very bottom and work our way up. So to talk about a lot of things we're talking about here, I want to talk about the basic injury mechanisms, because I think it'll help you understand the injuries that occur and then how we treat them. So these are my disclosures. None of them are really relevant to this particular topic. This is where it all started for me. So I did this study when I was in residency, back when I first met Brandon. And what we did is we looked at injury rates in high school and adolescent pitchers and found that they are remarkably high. And this is something everyone here knows, but the reason why you're listening to me is because there is a substantial problem with injuries in pitchers. There's 30% of them, even as high school and adolescent pitchers, that have been injured. A lot of them have been in physical therapy. A lot of them have pain with pitching. And these numbers are going up. So this problem is getting worse every year. This is the number of ulnar collateral ligament reconstructions performed every year at the major league level. And you can see that the numbers have risen every year starting at about 1997. And the thing that's interesting is that we've worked to solve this problem. So we have described the association with pitch counts. We've put in place pitch count recommendations. We've put in place all sorts of things to try and solve this problem unsuccessfully. Despite our efforts, these numbers continue to rise. So I want to talk about what's causing that and what we can do about it. To understand that, first you understand how the pitch works. And the pitch is an alchemical motion. And the basic way that it works is the force is generated in the legs and the core, and then it's translated onto the arm. So it starts here with a stride. The stride downhill creates a lot of force. And you can see during this time, the arm is still cocked, the thorax is still cocked. And then you have rotation forward, and then all of it gets translated through rotation to the humerus and then through the forearm and onto the ball. So this is from our lab. And basically there are two sides to the pitch. There's this part up to this moment. This moment right here is called the late cocking or acceleration phase. And at this moment, all of that energy was created in the legs and in the torso has been translated and is stored in one potential mode, potential energy of stretch of the capsules of the shoulder and the elbow. At this moment, the ball is pulling backwards, the arm is rotating forwards, and then you get rotation of the arm onto the ball, and then all the velocity is put onto the ball. So this moment is basically the moment you need to worry about. Is when the arm is rotating, there's this medial distraction and lateral compression across the elbow as the inertia of the ball pulls backwards. And on the elbow is basically a hinge from an osseous perspective. And it's stabilized a lot by the way the bones fit together, but also by the lining of the elbow joint, which is called the capsule, which is thickened in certain locations into ligaments. And the one that we care about the most in baseball is the ulnar collateral ligament, or the medial collateral ligament on the inside. And this is that ligament. And the portion that matters is the portion here outlined in black. That solid black is the anterior band. And you can see that band is the same length, no matter what rotation of flexion or extension the elbow's in. And that's the key here. So because it's the same length, it's the portion that matters the most all the way through the pitch. And if you cut that, then all of a sudden the elbow can gap open. And this is then what you will see on the MRI. You'll see a discontinuity in between the lower arm bone and the upper arm bone, the ulna and the humerus, in that ligament. And typically this is what we do about that if it's a full thickness tear, which is to reconstruct it using a graft, or increasingly if it's a partial tear, to repair it using an internal brace. So all that is to talk about what causes the injuries and what we typically do about them. I want to spend a lot of the rest of the time talking about, could we predict these injuries before they happen and thus prevent them? Because if we could prevent them, it would be much better than having them ever occur to begin with. So I'm going to talk about a bunch of different factors. And the reason I want to talk about this is because there's a ton of different research on this, and these different factors come together in different ways. The first factor, and the factor which originally thought to be important but has been shown subsequently not to be important, is pitch type. So it was originally thought that breaking balls, the curve ball, the slider, were more harmful or more likely to cause injury than the fastball. And that's been basically debunked. There is not more stress that goes through the arm when you throw a curveball than when you throw a fastball. The fastball is more stress. So that's thing number one. We can get that out of the way. These are the factors that do matter. So in that same study I showed you earlier, where we had those 420 pitchers, we looked at correlates between injury and other factors. These are the three factors we found matter the most. Number one is height. So taller pitcher, more likely to be injured. Every 10 inches of height adds 20% injury risk. If you play for more than one team, and this is way more applicable to the high school and the adolescent and the youth pitcher, of course, than it is to like a major league pitcher. But this is a workload factor, and we're going to talk about this. If you have more workload, more likely to be injured. So 2 teams, 22% more risk. Higher velocity, more risk. So 10% more velocity, 12% more injury risk. This is where the rubber really hits the road. When you look at a continuous variable like that, what you really need to find is what's called the dose-response relationship. Now, the dose-response relationship is the basis for a lot of our understanding of medicine for when two things are causally related, as in when problem A causes problem B. This is what you find in velocity. The more the velocity goes up, the more the risk for injury goes up. So if you're a youth pitcher and you only throw 50 miles an hour, your risk for injury is low. If you're a pitcher and you throw 80 miles an hour, you've got a problem. You've got a 50% chance injury. This holds true at the major league level. So I subsequently looked at all of the pitches thrown over a 7-year period of time. It was 7 million pitches we looked at here. And we connected each pitch to a player and then looked at whether or not that player subsequently needed injury. And this is what we found. So if you throw 96 miles an hour, there's a 20% chance you're going to need to have an ulnar collateral ligament reconstruction sometime in the next couple of years. If you only throw 87 miles an hour, there's a 5% risk. So that's a tripling. You can see it's a huge increase in your injury risk as the velocity goes up over this narrow band. The other thing that matters is your weight. So if you're a heavier pitcher, also substantially higher risk for injury. So here's how I can connect these risk factors with what I showed you at the beginning, that rising rate of injury. Velocity is going up. So every year, the mean velocity in Major League Baseball ticks up. Weight and height are also going up. Our pitchers are getting bigger. I'm not the only one that's shown this. So there's another group, Eric Machny out of Henry Ford. He's shown the same thing, that there's a direct correlation between ball velocity, body mass, and arm length, which correlates directly with height, and the amount of stress that goes through the arm. And this is physics. So this is just you can understand this, you can understand a lot of what I'm talking about here. When you pitch a baseball, the energy that goes onto the ball has to come through the elbow. The longer the forearm is, the more lever arm there is between the ball and the elbow. The heavier the forearm is, the more lever arm there is on the elbow. And the faster you try and pitch it, the more force has to go through the elbow. So those three things, which again are like high school physics, can explain a lot of what I've just showed you, which is that heavier arm, longer arm, faster pitch, more stress through the elbow, more likelihood the ligament will tear. Okay, that's all well and good. The problem with it is that the velocity is baked into the game of baseball. So if you look at the distance between the mound and home plate, and you look at how long it takes a pitch thrown 85 miles an hour or 95 miles an hour to cross that distance, and then you compare that, the amount of time the pitcher spends with the signal traveling between the eyes and the brain, and the signal traveling between the brain and the legs, and how long it takes to swing a baseball bat. At 85 miles an hour, there's about a tenth of a second for the batter to decide when to swing the bat and where to put it. At 95 miles an hour, there's about a 20th of a second. And you can extrapolate forward to understand that by the time you get to 105 miles an hour, the batter just has to swing. There's no time to decide when to swing or where to put the bat. You just have to swing. Compare that to the human ability to pitch a baseball, and you'll know that 100 miles an hour is probably about the limit. So exactly, philosophy is baked into the game of baseball. So we're not going to fix that factor, but understanding it will help you to understand who can get injured. So here's what I've tried to do next. So we went through all that, and I thought, okay, well, there's got to be a way to actually reduce injury risks, or at least understand how the ligament responds to load so that we can make it less likely pitchers will get injured. And this is what we did. So using the Angel system, we went to spring training, and as you can see, this is right outside of the minor league facility in Tempe that the Angels have. And what we did is we ultrasounded the ulnar collateral ligament both at the beginning of the season, the end of the season, and the beginning of the next season in every pitcher in the system. And ultrasound is a beautiful tool for this kind of thing. You're probably mostly familiar for looking at babies in utero, but it's great for this kind of thing because what it allows you to do is see the ligament in beautiful detail. It tells you how thick is the ligament, and then you can stress the elbow and understand how much does the elbow open when you open and stress, which tells you how much the ligament functions. Here's what we found in our study, which is that during the season, as pitchers pitch, the ligament responds to stress. It gets thicker, and this is even more so in higher velocity pitchers. So the more stress you put through the ligament, the more beefy, the more tensile load the ligament will be able to handle. The other thing we found is the ligament itself gets longer. So the ligament is able to accommodate more laxity as the season goes on. During the offseason, both of these things reverse. So when the pitcher stops pitching, the ligament gets smaller and it gets shorter. This matches with everything we know about load in other tissues. So this is from a study that Glenn Fleissig did. And Glenn Fleissig has taught us a huge amount about pitching mechanics. This particular study is just a beautiful demonstration of exactly what I told you earlier, which is he took CT scans of dominant versus non-dominant arms in former pitchers and found that the humerus is substantially thicker, as in the bone is thicker. The bone is thicker, and not just that, but the bone changes shape. It goes from being a triangle, which is better able to resist bending stress, which is normally what your upper arm bone does, to being a circle, which is better able to take rotational stretches, which is what it does when you pitch a baseball. So the bone responds, the ligament responds. This is the exact opposite of what we've previously understood. Previously, you've heard workload is bad, workload leads to injury. What I'm showing you here is workload is good. Workload causes the ligament itself to strengthen, and it causes the bone to strengthen. And those things may therefore be protective. So what I'm telling you is that in the future, we need to balance those forces, understanding how do we get enough to get the ligament to be strengthened to resist injury, but not be too much so it's too much for the ligament to adapt. What about mechanical flaws? And this is the other thing that I think a lot of us have tried to understand. What is it about the way that the pitcher throws the baseball that leads to injury? And we've looked at this extensively in a large number of pitchers, and this is the main factor we found that associates. And I'm going to explain to you what it is and then how it works. So when the pitcher throws the baseball, there's a moment in time in which the hips are rotated towards home plate, but the shoulders are not. That moment is when the core, the lumbar spine, the obliques, the rectus is carrying that potential energy that was created with the stride. When the pitcher gets fatigued, or if the pitcher doesn't have proper form, that moment doesn't exist, and the core no longer holds that energy. So we found that factor, whether or not there was separation between rotation of hips and shoulders, or commonly known as pitching with a closed shoulder versus an open shoulder, had a significant correlation with injury. It also correlated with better velocity. So if you could engage your core, velocity goes up. So this factor may be associated not only with less injury, but also with better velocity. Here's where the rubber really hits the road. We then have pitchers pitch a complete simulated game. As the game goes on, the pitcher's core fatigued first. The first thing that happened as they got to 90 pitches is they had less and less separation of the hips and shoulders, even though their arm looked good. Here's how this works, I think. So this is where I'm from in Portland, Oregon. This is the Willamette River. You can see the city of Portland down the river there. This is where the water comes from Willamette River. This is Hurricane Ridge at Mount Hood. It comes from snowmelt. Snowmelt comes out, as you can see, not at a very controlled fashion. In between here and Portland, there's this, multiple dams. The dams slow the force of the water so that it can come out at a controlled rate. If they don't come out at a controlled rate, then you get this, you get a flood. This is what happened when I was a child in Oregon. All the dams released at the same time. The water rose 20 feet in the space of 24 hours. The same thing is happening here with the pitcher. The core is a dam that allows the energy you create with the stride to be applied through the arm in a controlled fashion, so there's no spikes in stress. Instead, the stress comes evenly up and down and never exceeds the load to failure rate of the umbilicolateral ligament or of the shoulder. So to me, that's how you make the rubber hit the road here. I'm not the only one that thinks this. There's multiple other studies that showed the same thing. So Solomito and colleagues showed the trunk rotation angle of ball release really associates very well with elbow torque. Keith Meister showed that there's a direct relationship between lumbopelvic control and the amount of force that goes through the elbow with the pitch. So the therapy that I then recommend for prevention is to work on the core. So you need to work on these single leg squats and these crossbody rotational things, especially with endurance, to try and prevent your pitcher as he gets to 90 pitches from tiring out and then leading to excess force in the shoulder and the elbow. This has actually been shown in a randomized clinical trial in Japan. So these Japanese investigators did this. They compared pitchers that did these exercises shown in this diagram. You can see a lot of them are core and shoulder exercises to those that did not. And this is what they found. This is in the control group. You can see that by the time they get to a year out, 40% of those pitchers have been injured. If you look at the intervention group, the group that did these exercises, half the injury rate, 20% injured by the time you get to a year out. So what I'm trying to tell you is that those things really work. So my hope is that gives you a little bit of a clue in how we connect understanding the risk factors for injury and the basic biomechanics to how can we then alter those things on a mechanical level to prevent injury. I'm going to turn this over to Brandon, who's going to talk to us more about the next step. Thank you.
Thank you very much. We're going to go to Brandon Erickson next. Peter, great talk. I thought it was interesting. Real quick, we got a lot of good questions already. Keep those coming. The Japanese study was fascinating because if I remember correctly, they only did the exercises twice a week, and they were pretty minimal exercises from our standards, and still got a great outcome. Brandon, you're up.
All right. Thanks, Dan. All right, you guys see everything good here?
Yep. Yes. There you go.
So that was a great talk by Peter, and Peter and I have known each other for a really long time. We've done a lot of work together, and it's been a real pleasure to get to collaborate with him. And certainly, Stan, we really appreciate you bringing us on this. And Nancy, thank you for always working out all the technical difficulties that we have from time to time. So we appreciate that. So Pete kind of set us up in regards to pitching, and I appreciate him doing that because he's basically an expert on the subject. What I'm going to talk a little more about is workload, because it's interesting. We talk a lot about workload in our profession, and it's not something that's very well defined right now. And so I think we need to do a little better job of defining this. These are my disclosures. They're not relevant. You will notice that same picture in that slide that Peter showed you before. That's courtesy of Bernie Bach over at Rush. So another shout out to some of our Rush people that help train us. So for this, we'll talk a little about what workload is, okay? How our definition of this is evolving over time, and maybe where it should be going in the future as we continue to learn more. Because as Peter said, we're trying to decrease injuries in players, and we've put some things into play, but we haven't been super successful in decreasing our injury rates. So if you do a search on on PubMed, you can come up with a ton of studies that talk about workload. You can see here, workload is mentioned in the subject of everyone, or the title of every one of these studies. And they all seem to define it differently, or they quite frankly just don't define it at all. Actually, Mike Freehill put out a good paper recently on looking at workload as a risk factor for injury, but they didn't really at any point in that review define what workload is. And the problem is it's kind of a nebulous term. It's a little bit hard to figure out. And so I think we need to do a better job of this. And so I say to you, what does it even matter? Why do we even bother defining workload? Well, if you look at some of the studies that are out there, and I thought this study from Chris Ahmad and Neil Eltress was excellent. they wanted to see if workload, okay, was a risk factor for pitchers needing a revision Tommy John. So they took some pitchers that had a Tommy John and went on to be successful, took pitchers that had a Tommy John and then went on to need a revision. They looked at games pitched, pitch counts, innings thrown 3 years before surgery, and then after their original Tommy John. And what they found was that pitchers who needed a revision surgery pitched a lot more after surgery than they did before. So in the revision group, they threw almost 7% more pitches after their Tommy John compared to before. And in the no revision group, they threw 20% fewer pitches after their Tommy John. So workload may be a pretty individualized thing that we need to figure out a little bit more, okay? So we've definitely seen some studies that correlate increased workload and increased risk of injury. We've also seen some good work by Chris Camp, who Stan mentioned before, and some of our Japanese colleagues that have kind of associated workload with a decrease in shoulder motion and a decrease in hip motion. And if you saw what Peter showed you before about how the pitch works, you really need to rotate over that front hip. And so if you're starting to lose some motion in that front hip as you get fatigued or as your workload increases, you're putting more stress on your shoulder and elbow, and it's increasing your risk of injury, okay? And the hope with defining workload is that if we can figure out the relevant factors of workload, well, maybe we can decrease the risk of injury by changing some of these factors. To Peter's point before about us trying to decrease injury risk in some of the adolescents, if we can define workload a little better, maybe we can decrease these injury risk and have an impact on some of the kind of epidemic or, pandemic of injuries, not to mention pandemic at a bad time. So how do we talk about workload? Well, I just mentioned to you, games pitched, innings pitched, and pitch counts all seem to be involved in workload right now, okay? Now, I would posit that there's a lot of other things that we should include as well. So what about pitch type, fastball percentage versus breaking ball percentage? What about percentage of fastballs that you throw in the first inning versus percentage of fastballs you throw in the sixth inning? Because I would argue that a fastball in the first inning, 2 men out, nobody's on base, 0-2 count, scores tied 0-0, is a less stressful pitch than throwing in the sixth inning where your starter's trying to get through the sixth inning, there's 2 guys on, you're up by a run, it's a 3-2 count. I think those are 2 different pitches, and I think we need to start weighing them a little bit differently. Peter mentioned average fastball velocity. It isn't to harp on the same subject more than once. We had obviously talked beforehand, but this is something to drive home. As people are starting to throw faster, we're seeing an increase in injury risk. So, for example, if you take a look at some of the Fangraphs data that's out there, and you look at the max fastball velocity that's been going on in the major leagues for the last 5 years, and you look at average fastball velocity, what you'll find out is that the teams who had the highest average fastball velocity back in 2010 compared to 2019, their fastball velocity has gone up about 2.5 miles an hour since then. And the teams who had the lowest fastball velocity also increased by about 2.5 miles an hour. So we know that fastball velocity is going up, and we can correlate that with injury risk. And then the same thing, peak fastball velocity. So not only the average fastball, but how fast you can throw when you really need to reach back and let it eat. If you look here, Pete showed you the study before. I'm not going to belabor the point, but I just want to show you this chart again. When you throw faster, whether it's average fastball velocity or peak fastball velocity, your risk of getting injured is going to go up. So this has to be included in our workload calculation, because we know that it's a significant risk factor for injury. When we look at this study by David Whiteside, they actually did a very interesting thing. They wanted to try to predict who was going to get a UCL reconstruction. So rather than a lot of the studies that we've done, we've seen what's happened to people and then we've gone backwards. They tried to predict going forward, and they created a model. And what they found was that having a smaller repertoire of pitches, so meaning throwing a higher percentage of fastballs, greater mean pitch speed, fewer days of rest between games, and then greater mean pitch counts per game were all risk factors for players sustaining a UCL injury, okay? So those are things maybe we need to include. But what about days of rest between outings, okay? Do we know the exact number of days of rest we should have between outings? And I would tell you no. 4, 5, 6 days, 7 days maybe do we need? Or maybe it's a little lower. Maybe it's 3 days. Maybe we've been thinking about this wrong and we're resting people for too long. Well, if you look at some of these studies that have been done in the past, the purpose of this study wasn't to look at necessarily injury rates, but this study was looking at the number of pitches thrown and what their effect was on days of rest and pitcher performance. So if you threw more pitches in an outing, did it have an effect on your ERA and your performance metrics in subsequent starts? Okay, they included a lot of pitchers over a lot of seasons. And what you can see here is a couple things. One, the maximum pitch count over the years has been going down significantly, as we all know. And the kind of variation in how many pitches are thrown in the game is also tightening up. You can see back in '88, they were throwing between 40 and 160 pitches, whereas that number's really tightened up now. Still centers around 100, but it's gotten much tighter as of 2009, and it's probably even tighter and slightly dropped down since then. What you'll see here is that if you look at the number of pitches that pitchers threw in the previous game versus the previous 5 games versus the previous 10 games, what you'll notice is that actually it's a cumulative effect over the last 5 to 10 games, because you see that their ERA starts to increase more based on the number of 10 games. So while it's important to know what they did in their last start, it's also important to know what they did in the last 10 starts, because that actually has an effect on their ERA as a cumulative kind of additive effect. Okay, and this is just showing you here that sometimes our older pitchers can more or better compensate for throwing more pitches in a single game, but if they have a significant increase in the number of pitches over 5 games or 10 games, that really begins to hurt their ERA. So there may be, as kind of Chris and Maud's study pointed out, we may need to let some guys rest for a longer period of time, and some guys can probably tolerate shorter days of rest, okay? And then what about hidden pitches? So we talk a lot about, pitches during a game and workload during a game, but we sometimes forget that there's a lot of hidden pitches that happen in the course of a game. And this is not just in our professional athletes, this is in our high school and college athletes as well. When you have guys warm up in between innings, or you have guys in the bullpen get dry humped and get up and sit down, etc., that can cause a significant number of pitches to be thrown that are never counted when we're looking at pitch counts over the course of a game. This study here was looking at basically high school baseball pitchers and trying to figure out how many of these players stayed within the recommended number of pitches per game, okay? So they counted the number of game pitches, but then they also counted the number of warm-up pitches. And what they found was that when you started to count the warm-up pitches, okay, there were a lot more bullpen and warm-up pitches than we really thought. And when you actually factored that into the number of pitches they should be throwing in the game, there were a lot of kids that violated the recommended pitch count recommendations here because they were going well over their number of pitches in a game. Now, should those pitches be counted the same as pitches that are thrown live in a game? Probably not. But is the ratio 5 warm-up pitches to 1 game pitch? I don't know. And I think that's something that we have to still figure out. So we talked a little bit about workload and mentioned a little bit about after surgery, but some of the questions that I get sometimes, I just wanted to put this out there for you to have an idea. A couple years ago when there were some pitchers that had some Tommy John and they were wondering if they could get back to throw and how many innings they could get back to throwing afterwards, we did a study looking at how many innings they threw in the year after they had their Tommy John surgery, and was that a risk factor for having a revision? And basically what we found was there's no magic number. 150 innings, 180 innings, there's no magic number to this. And again, back to Chris and Maud's study, it's probably an individualized amount of workload. So it's hard to put just some arbitrary number on something, 150, 180, whatever that number is. It's hard to define it with just a single number for everybody. So it has to be individualized to that person. So it's important to keep track of what these guys do, both before they get to you and then after they go on. You can't just take them as a snapshot in time of 1 year, because that's going to do them a disservice. If you actually take a look here, this is talking more about length of time following surgery and when they can get back to their workload. And I just wanted to mention this because when we're having guys go back to their full workload, okay, it's very important to make sure they are at peak performance level when you let them go back, right? Tommy John surgery is a big surgery. It takes a long time to get back from. And when we looked here, what we found was that when guys went to their back to their previous level who did not need a revision surgery, right? They had a Tommy John, they successfully came back and didn't need a revision. It took them almost 18 months to get back to the same level. When you look at guys that needed a revision Tommy John, they got back just over 15 months. So 2.5 months earlier than the guys that didn't need a revision. So when we're talking about workload and letting somebody go back to their full workload, you just need to have in the back of your mind after they have a surgery, potentially an injury, you want to take it a little slow with these guys, because while this wasn't statistically significant in our paper, to me, this is very clinically relevant. And so I would say don't rush these guys back to their workload. They can probably go back to pitching their same workload after, but you have to let them get there, and whatever time it takes them to get there, you have to be okay with that, okay? And so I want to talk a little bit about, some of the kind of new and exciting things that we're doing in regards to workload, because a lot of the studies that have been done on workload have been, retrospective per se. So somebody has an injury, we go back and look to see what they threw beforehand, what they threw afterwards, try to find a correlation. And they're good studies, but there's always some problems with that, right? Because they're retrospective, there's some bias that gets introduced to that. So we're trying to figure out ways to better measure workload and better ways to include what we think should be included in workload. So Peter and I recently have been trying to look at the association of workload with injuries within Major League Baseball, okay? So what we're trying to do for pitchers, we're using days of rest between outings, innings pitched, and batters faced, because there's a limited number of data points that we can use in the available data sets. And then for position players, we want to talk about days of rest, innings fielded, and plate appearances as the workload that we can define for these players, and then seeing if there's an association with this workload with injuries, okay? So there's a few studies that we're actually working on right now. For pitchers, we're looking at the association of workload with UCL injuries, oblique strains, internal impingement, and lateral teres tears. And for position players, we also did oblique strains, hamstring injuries, because this is one of the most common things that we see, concussions, and calf strains. And kind of like I said, the way this works is we combine two data sets. So we combine the hits data set, which I'll explain to you a little bit later in the next talk, and some player usage data over hundreds of thousands of players and hundreds of thousands of player exposures. And it really allowed us to look at workload as it related to injuries, because nothing's really done this before on a large scale like this. And I wanted to share with you a couple of our preliminary results. These aren't published yet, but these are some things that are going to come out soon. So in regards to Tommy John surgery, okay, when you look at all the time periods that we kind of evaluated, we found that players that actually had more days of rest, okay, so that's not a typo, that's more days of rest, more innings pitched, and more batters faced, was associated with sustaining an injury to the UCL. We found that pitchers who threw 4 or more innings in an outing had almost a 2-fold increase in the percent of players that had an injury to their UCL compared with those that only pitched an inning. And we also found that being a starting pitcher was a significant risk factor for sustaining a UCL tear, about a relative risk of 1.5. So let me show you a couple of charts here. So on the bottom left, that looks at the percent of players who had a UCL tear in the subsequent 12 or more than 12 weeks in kind of the time frame that we're looking at, and the number of days of rest that they had between outings. And what you'll notice there is that kind of it's flat line between 1 to almost 4 days, okay? And then when you start to actually get more days of rest, when you go to that 5 days of rest, their risk of having a UCL tear actually goes up significantly. So if you look at that picture, that chart in the middle there, what you'll see is that innings pitched, same thing. So as you increase the number of innings pitched past 3, kind of 4 innings, you start to see a linear increase in the percent of players that had a UCL tear. And then if you look at that bottom right chart, you'll see as the number of batters faced went up past about 15, the percentage of players that needed a Tommy John surgery went up significantly as well. So of course you'd think inning pitched and batters faced would result in an increased risk of UCL tears, but an increased number of days rest past 4 days actually was a risk factor as well. So the question is, are we thinking about this a little bit or kind of the wrong way? Should we be having guys throw 3 or 4 innings in a game and that's it, and letting them throw on fewer days rest, like 3 days rest? So rather than having them stretched out on one particular game, have them pitch more games, but at a less number of innings per game. This is just all kind of food for thought, because we're still working on some of the other parts that go into this equation. When we look at hamstring injuries in position players, what we found was kind of everything you would think. Fewer days of rest, more innings fielded, more plate appearances were all risk factors for subsequent hamstring injuries, okay? We found that when they had more than 5 days of rest, they had a significant decrease in the risk of a hamstring injury, which, really isn't something that's possible the way baseball is currently structured. And as they fielded more innings, they had an increased risk, et cetera. And as I can show you here in these charts, same thing as before. So as the number of days of rest increased, the likelihood that they were going to sustain a hamstring injury went down significantly. As the number of innings fielded and plate appearances went up, the risk of sustaining a hamstring injury went up significantly as well. And so this kind of goes with what you would intuitively think with this, not like the UCL issue. And so I want to kind of just bring it home with the things that I personally think should be included in workload. And this is my personal opinion, so take it for what it's worth. Certainly innings pitched, games pitched, pitch counts, and batters faced. That all should be a part of this equation, okay? Pitch type, absolutely has to be at least a part of this equation. And I think that fastballs need to be weighted more than breaking balls. If you saw what Peter showed you before about different stress and strain on the elbow, and there's different studies that talk about different things, but we know that fastball velocity is a risk factor for injury. So you have to weight a fastball, in my opinion, more than a breaking ball. When the pitches are thrown, we talked about this. High stress pitches, I think, should be weighted more than low stress pitches. Now, the thing is, you have to know that high stress pitches for one person are not the same as high stress pitches for another person. When I had the opportunity to work with the Mets when I was a fellow, I'll tell you, there's not a lot of pitches, or there's not a lot of game situations that phase Jake DeGrom. So, even if it was, not that he pitched in the ninth inning, but bottom 9, 2 outs, bases loaded, 3-2 count, that pitch probably doesn't cause him as much stress as it would some other players. So it really has to be individualized to the players. Kind of mentioned fastball velocity before. I think that the faster players, the fastball as the players throw, the higher weight you have to give to those fastballs. And I think days of rest between outings has to be considered. So maybe it's more days rest, maybe it's fewer days rest. It's probably related to how many innings you throw. So if you're throwing 2 or 3 innings in a game, the days of rest should probably be shorter. If you're throwing more innings, the days of rest may need to be longer, but maybe not. This is something we still have to kind of tease out as we learn more about this. And then hidden pitches. I do think hidden pitches play a role here. I do think we have to account for these. Now, I certainly think they should be weighted much less than a game pitch, but the hidden pitches absolutely have to be taken into account if we're really trying to figure out or really trying to make a formula that we can use for our workload. So I challenge anybody on this webinar right now, come up with a formula that you think includes these things and weights them in a certain way. I know there's a lot of people on this call that are smarter than I am. So if you can come up with some kind of algorithm that includes these things in it and weights things differently, I would love to see it. It's something I'm working on, but I haven't quite perfected yet, so I'm not going to share with you quite yet. A couple of things just to mention on the horizon. Pete and a lot of the other baseball faculty that have in different things have been really great at sharing their knowledge about issues with the elbow and biceps and things like that. So these are a few books that are coming out soon, and I think a lot of these topics wind up getting discussed in these books for those of you that are interested. All right, so thank you. So I think with that, Stan, we could probably start answering some of the questions before we go on to the second set of presentations.
Yeah, absolutely. Peter's on, that's great. We have a huge number of questions, more than we've ever had in an entire process. I have a whole bunch of questions that I think I'm going to hold off. I want to get most of the ones from the audience. And Nancy, why don't you pick a couple? We've got a group of them on weighted balls. So I think we ought to just go after that right now. So why don't you just read one of the ones on the driveline weighted ball situation?
Okay. What is your opinion on the safety of overload throwing training programs? Example, plyo balls in a driveline program.
Yeah. Maybe can I say one thing, and then I'm going to hand over to Brandon. So there's been a randomized clinical trial looking at heavier overweight balls that was done by Dr. Glenn Fleissig that showed it was halted early because there were so many injuries in the heavier ball group. Their velocity did increase, so it worked, but it came at a pretty steep price. And to me, this gets right back to the physics I showed you earlier. If the ball is heavier and the arm is going to move at the same velocity, it has to put more stress through the elbow. So to me, I worry about that. I want to let Brandon talk about something he's done with lighter weight balls that I think is another alternative to maybe accomplish a similar goal.
Yeah, I agree with Pete said. I think you have to take weighted balls and look at them as two separate things. Are you using heavier balls, not throwing balls that are more than 5 ounce, 6, 7 ounce balls, but are you using heavier balls as more of a muscle training thing where you're not having pitchers throw them like they're regular balls, or are you doing that in an attempt to try to increase their velocity? I agree with Peter. I think not used properly, or when they're trying to be thrown like regular baseballs, they really do increase a player's risk for injury. They're effective, like Pete said, but it does increase their risk for injury. So one of the things that we tried to figure out was, all right, well, maybe lighter balls, because as Peter mentioned, as you have a bigger lever arm and you have a higher weight in your hand, you're putting more stress on the elbow theoretically. So, okay, so what if you put a less stress on the elbow? So you use a lighter ball. So a 3-ounce ball, a 4-ounce ball, and then also a 5-ounce ball, coupled with some other core strengthening and flexor pronator strengthening program that Pete and I kind of harp on because we think is very important. And what we found is over the course of a training program that involved these lighter balls, we actually found a significant increase in players' velocity. This was in adolescent players, but their velocity went up almost 5 miles an hour per player, and nobody got injured. There was a guy who broke his ankle playing basketball, so he was excluded, but nobody got injured while they were throwing. And so this was a very small sample size and very preliminary results, but it really just was meant to start the conversation of, are weighted balls the answer, or should we maybe think about using lighter baseballs coupled with some other core plyometric strengthening things? And I think that's probably the way to go. But, you know, Pete, if you have, or Stan, you know, if you want to weigh in on it.
Let me weigh on it a little bit. I think Lynn Fleisig was part of that study. The main author on that was Mike Reinold on the weighted balls that looked at the two cohorts and showed, I think, a 24% increase in the weighted ball program. You know, again, that was not a big sample size. It was an excellent study, but it was a small sample size. I think that the problem that occurs is the player who's at the end of his career and has the one more shot. The senior college guy who throws 89 miles an hour, but the velocity is not going to get him drafted. So his college season, his college career may be the end of his career, and he needs more velocity. There may be types of people who might take the risk reward aspects to try to increase their velocity 3 or 4 miles per hour to get them into that group. We have a guy right now who I've actually talked with Dr. Erickson about. He's a super senior. We call them super seniors, and they've been to school like 6 years, and he was draftable but didn't get drafted, so he has another year of his senior year. So we went to lighter balls, the program that Dr. Erickson lays out in great detail in his paper. We've been doing it for about 6 weeks, and we've increased his velocity a couple miles per hour, just doing everything the same except for incorporating lighter balls. So I think the idea would be the candidate you pick. That's the most important part. You pick a 16-year-old that throws 85 miles an hour and wants to get to 90 and put on a weighted ball. I think that's criminal. I just think it's criminal. There's no big reward and there's a lot of risk. So I think it depends on the player that you're at. There's some that were willing to take the risk. Make sure that the player wants to take the risk and not the parent or the coach. So Peter, I was fascinated with your forearm physics. I think that article was a fairly old article that was written. My eyes don't work as well as more to see the small print. I think it was way back in the 1980s that really talked about that. And I did know a couple years ago there was a team that was measuring acromion to middle finger to look at arm length. I don't know if they ever did anything with that. They were looking at it as a positive, not a negative. Has anyone that you know of done a study looking at forearm length in relation to Tommy John? I don't think I know of anybody, but maybe somebody's out there doing something.
I'm not aware of a study that's looked at that. One of the things that we've looked at in other research is I've looked at a number of different shoulder anatomical measurements like scapular width or humeral length, and all of them correlate very closely with height. So the upper extremity in general is very closely correlated with height. So you could do that study, but I suggest that if you were to look at height, you're basically looking at the same thing. The R value in general between shoulder anatomical length measurements and height is about 0.7, which is pretty good for biology. So certainly there are players that have longer arms, and people don't talk about that very often in baseball. People talk about it all the time in basketball, like wingspan as compared to height. But there's that variation is more tightly controlled genetically than you might imagine in development.
In regards to the height, are you talking about height in professional sports? We know we have a lot of studies that looked at height in the adolescents as an increased risk, but the information you provided today is talking about professional athletes in other words, adults.
Mm-hmm. Major league pitchers. Major league pitchers. More height correlates with more injury.
Yep. Nancy, on the next question, I see Glenn Fleisig's in the queue. Well, we ought to get him because he'll get pissed off if we don't ask his question.
Oh, he's got a couple. Let me scroll back here. Stan, which one are you going after here?
You can just pick one.
I'll read it. I'll read it. It's Brandon might get these 2 points, but I wanted to get this point in the case he doesn't touch base. A couple more issues on workload. One, stress per pitch, torque with biomechanics, and two, how to add the stresses in pitch to pitch. For example, a one full effort pitch, the same workload, less workload or more workload than the two half effort throws. I think he's looking at intensity in regards to velocity, the difference between throwing a 95-mile-an-hour fastball and a 90-mile-an-hour fastball in regards to that.
Yeah, I mean, I think that's, you can definitely take it as either how hard they're throwing when they're in the game, or you could even relate that to the warm-up pitches and getting up and down in the pen. I think that's definitely part of it, Glenn. I think, and I'm looking at you, Glenn, to come up with this formula, because I think we really can come up with a formula to figure out what an individual person's workload should be. The torque thing that you said is exactly right. And that was kind of, it's kind of a more drilled down sense than what I was talking about pitch type, and obviously different amount of torque versus with different pitch types. And certainly some of the mechanics that Peter talked about obviously come into play with that as well. But I agree with you. I think, throwing harder, and that gets to the when the pitches are thrown argument. So first inning versus ninth inning, bases loaded, nobody on. I think there's a difference there. And you'll see that guys sometimes will try to overthrow and they spike the ball into the ground. We know that they tried to overthrow it a little bit, and they probably put a little more stress on their elbow with that throw than they did on their, opening pitch.
Yeah, I just want to jump in on here because Glenn asked that question specifically later in regards to the stress, mental versus physical. The question, I've talked to a ton of pitchers in saying with bases loaded, nobody out, is there more stress on you? Do you throw harder? And they say yes, but the gun says no. And so, again, in regards to like the workloads on warm-up pitches, Nancy and I actually did this with the Dodgers many years ago. We asked the bullpen coach to count the number of throws a reliever was doing before he went in, not to include just the warm-ups. Once he got on the mound and threw down to a catcher, they started having the numbers. First of all, again, this has to do with the overall accumulation of workload data. What we found was that the bullpen coach lied. We actually videotaped the bullpen and went back and counted the pitches, and he had dropped the number of pitches by 20% of what they actually did. And this is also on the dry humps. When you ask a reliever, how many times did you get up and get down? They typically say 4. Well, the video shows they got up twice. So one of the things with workload that's really important when you get these unaccounted workloads, you got to be able to look at it. And I think in bullpens, which we did not do at the time, you need to look at velocity, intensity, because again, how do you grade those versus a pitch? We know almost always, and we can show this on with mile per hour data, is that the pitcher, even a starting pitcher now, throws a maximal throw on every one, whether it's a breaking ball, whether it's a fastball. So there's no less than in a game that I've seen and data that I've seen. But the unaccounted ones I think are really, really important, but they have to be, looked at differently, and there has to be a percentage of that, and how does that count against the total to be able to do a good study. So that's my thoughts on that, and that's Glenn's idea. I think he's, if I read him right, He believes the mechanical stress is more than the emotional stress, and there may not be a relationship between the two, even though the pitcher says that.
So I would say you're probably right, but my kind of I guess devil's advocate to that would be, do you think their mechanics change when they think that they're throwing harder? So have they changed their mechanics from when they think that they're not throwing as hard versus when they think they're throwing harder? To get back to, what Pete talked about before about, stress based on what their mechanics are like. That would be the only thing that I would say. Do their mechanics take a little bit of a hit when they try to overthrow and throw harder, and therefore those pitches should be weighted more? I don't know, and I agree with you. The gun doesn't lie, but the gun doesn't tell us what their mechanics are doing.
No question. I think you can get some of that information on PitchFX, but also wearables. If we ever got into wearables, I think we could do a lot better with that. TrackMan too, in regards to that, and being able to at least look arm slots. And you also look at spin rates, which might have something to do with it. Again, more workload data that needs to be collected and put together. I think we're scratching the surface on workload, in regards to what we had to put all the way into that. So anyway, okay. Let's see.
And I have one that kind of goes along with what you were just saying. Someone asked, how would you recommend the difference in stress on the medial elbow for flat ground throwing versus lower intensity mound throwing?
This has actually been looked at. Glenn looked at this in a study a while ago and showed that long toss is just as much stress across the elbow as mound throwing. And I think it makes sense, given how much energy has to go to the ball to throw the ball 180 feet. So I talk to our pitchers here about that a lot, because there's a lot of folk wisdom that long toss is less stress on your arm. And that's not really true. What it may be is it may be a more controlled way to apply that stress. So one of the ways in which long toss may be helpful is that it allows you to stress the ligament and build it without having to go through the stress of, like a 95-mile-an-hour fastball. And I think to me, that's probably the next step in everything we're doing, is determining how do you stress the ligament so that it can build and adapt to prevent future injury, but not stress it so much that it tears. And that's going to be a balance. It's going to be hard to hit, but I think long toss may be one of the ways in which you can get there.
Again, I think it does depend on intensity. Are you talking about a long toss where you loop the ball, 100, 180 or even 250 feet, versus throwing on a line as hard as you can? So again, there's that intensity. When people talk about long toss, it's another whole series of information on what is long toss. It's sort of like what is workload. It's the same thing. Listen, I'm going to have to wrap this up because we still got 2 more presentations. I apologize for all the people who have written. I mean, we've got 50 questions here. We'll try to get them back on the next end of this, but the next 2 presentations are pretty educational, so I want to get to them. So Peter,
one more. There's several questions about the ultrasound study. So I'm just going to try to summarize them. So based on the results from the ultrasound study, a lot of people are asking about recommendations of what to do in the off season. Do you have them throw year round? How long do you recommend that they take off? Like, how long does it take for the UCL to get back to the preseason length?
That's those are all great questions and all next steps for us, because I think that those are going to be important determinants. How long does it take to detrain the ligament? Obviously, it's going to be helpful to have some time off. So I would not use the results of the study recommend that people pitch year round, or that you should never take any time off. But I do think that there's probably going to in the future be some sort of ligament training exercises people will do in the off season to try and apply that stress while not pitching. And again, that's we're still in a relatively early phase with this. That study was just published, so stay tuned.
Yeah, again, I don't want to sound like a broken record, but then the definition of throwing comes in. So when people do a throwing program in the off season, that's a whole different thing. Can you throw at 50 or 60 miles per hour and do that without putting a lot of stress on the UCL, but still keep the throwing and the shoulder motion together in the off season. So again, you get into these, what are you talking about when you talk about throwing? And pitching year round is ridiculous. That's competitive pitching. That's what we talk about. But the throwing, so some people think you're supposed to take 4 months of not throwing, and that's not what we're saying. It's 4 months of not competitive pitching. Okay, we got to move on, guys. I'm sorry. God darn it. I wish we could just sit here and ask questions all day, but we're going to go on, and Peter's going to give his next presentation. Okay, Nancy, set us up.
All right.
All right. Hopefully, you guys can see my screen. The idea here is we're going to talk about another body of work Brandon and I worked on together to look at return to play. And I wanted to give us a chance before we talk about that on what we mean when we say return to play. And this gets back to a lot of what Stan's been talking about defining defining our terms. And I want to talk about why this is important first. So everyone on this call has read studies that say ulnar collateral ligament reconstruction, 90% return to play. I want to talk about why that number may not be what you think it is. So this is all in terms of how you define success. And as you know, success is relative, and you can be happy or unhappy with different things. It all depends on what you had hoped to achieve. So I'm going to go through a couple of examples here. So we'll start with the major one, ulnar collateral ligament reconstruction. So these are 3 of the major studies that have looked at return to play after ulnar collateral reconstruction. And this is how they define return to play. They said if you pitched more than 0 pitches in more than 0 games at any level, then this was the likelihood of success. So Andrew said 90% success if you could throw at least 1 pitch in at least 1 game. Noonan with the Rockies, 100% success with this definition. Ahmad, 80% success. So these numbers are what you've typically heard, which is 80 to 100% success rate with this procedure. Everyone in this room has heard those numbers. That's where they come from. Here's the problem. The player doesn't care if they only pitched 1 pitch, at a single A level, if they were previously a triple A pitcher. So I would add that you probably need to say at the same or a higher level at the very least. And then you start to see these numbers drop. So all of a sudden now, Andrew's reloads don't look quite as good. So now you're saying 76% of pitchers got back to at least 1 pitch in at least 1 game at the same level or a higher level. This gets even more complicated, and I want to show you another example. So this is a study we did where we looked at all of the players who had shoulder surgery in all of the MLB. So this is, I think, over a 4 or 5 year period of time. There's 384 of them. So 100% of players had surgery. If you said how many players played in more than 1 game at any level, then 63% of them would be counted as return to play. So those numbers are already not great. 63%, you'd say, God, that's 2 out of 3. I mean, I wish it was better than that. But that's at any level. Let's start to really drill down on what we mean by that. Most players would say, I at least want to get back to where I am now, or at least where I was before I was injured. Then you start to see a degradation. Now it's only 54% of players that will get back at least to their prior level. Here's where this gets really hard, though. If you're a AA player, your goal is not to return to AA. Your return is to get to the majors. That's your goal. I mean, you would say, if I only got back to AA and all the guys I was playing with advanced, I would not consider that a success. So when you break this down to, did you get back to a higher level than you were before injury, or did you get back to the major league level, then all of a sudden the results are much worse. It's only 39% of players. So we've gone from 2 out of 3 players to 1 out of 3 players success. So again, I think you have to carefully define success here. And this gets even more complicated because then the question becomes, well, for how long? Nobody pitches professionally forever. I mean, if you look at the current oldest pitchers, no one's over the age of 40. Now, traditionally in my field, when we judge our outcomes, we look at 2 years, we look at 5 years. 2 years is considered short term, 5 years is considered middle term, 10 years is considered long term. These outcome numbers may be completely meaningless for major league pitchers because by 10 years, none of them are pitching anyway. So this is where we tried to analyze this in that same cohort. So this is that same group of pitchers that had shoulder surgery. And what I want to show you here is that when you were 1 year before the injury, everyone was playing, some of them in the minor league and some of them in the major league. The year of surgery, of course, a bunch of people, they had surgery, they couldn't pitch. But then if you look at every year thereafter, every year there's fewer and fewer of them that are in the league at any level. So if you draw the line at 1 year, your numbers look way better than if they draw the line at 2 years. And if you say, well, I want to know how many pitchers are playing at 5 years, almost none of them are pitching. So this is a problem. This is a problem because now we don't know where, if you were to ask the average player, how long do you want to play professional baseball for? They're going to be like, forever. I want to continue doing this forever. But we can't use that to judge success here because no one plays forever. So one of the things we tried to do to drill down on this is we tried to look at a group of players that had ulnar collateral reconstruction. We had 153 of them. And for every one of them, we determined what was the reason why they retired. What was the reason why they left Major League or minor league baseball, left professional baseball. And we figured out, we assigned them all a reason. And then we matched them to control pitchers. So we took 153 pitchers that had never had ulnar collateral reconstruction. We asked them the same question. Why did you retire? And the interesting thing you find is that the reasons are different. So you might expect that if you'd had an ulnar collateral reconstruction, the most common reason for retirement would be because my elbow had problems. That's not true. If I looked at our UCL players, very few of them said that the ulnar collateral ligament reconstruction was the cause of their retirement. Very few of them said that the shoulder was the cause of retirement. Instead, most of them said, I couldn't play anymore because my performance wasn't good enough to stay in the league. Compare that to the controls, who were more likely to say that their shoulder was the reason or their elbow was the reason, and less likely to say that their performance was the reason. So then this gets really hard, because is it that the ulnar collateral ligament reconstruction negatively influences your performance, and so therefore their performance was not as good? Because theoretically, if these are matched pitchers, they should have the same rate of performance attrition. So I will tell you that as we did these studies, I really scratched my head to try and figure out how we could accurately define success. Here's where it got even more complicated. Then we started to look at performance data. And I said, oh God, I mean, there's a lot of pitchers where they get back, but their performance sucks. So if you look at rotator cuff surgery, for instance, and I think a lot of people that have worked with players that have rotator cuff surgery know that that's a very hard surgery to recover from. Even among those who returned, which was the minority of them, their performance was substantially worse. They had fewer wins per year, fewer games started, fewer innings pitched. Probably most important to everyone, their wins above replacement was lower. So these players are counted as a success in the previous slide I showed you. These are the 39% that got back. But even when they got back, they weren't as good. And I would say that these players would not consider themselves successes. So if a player says, I got back, but I wasn't really very good and I wasn't good enough to play for very long, I'm not really sure we can count that as a success. I don't think that player would count that as a success of our treatment. Okay, this gets even more complicated because performance degrades with age. So if you look at control players, their performance starts to go down as they reach advanced ages. So it's not even as though I can look at these numbers and say, well, maybe this is normal. Maybe their decline in performance was what we would have expected otherwise. So this is how we've defined success in the studies that Brandon is going to show you. And I think this is the best definition, but you could argue with me. I think that you can only define success if your post performance was no different than control players matched by draft year, and not just performance, but your rate of return to play. So if the likelihood you were still in the league a year later is the same after surgery as it would have been, and you've just been normally playing, I think we can count that as a success. The reason I mention that is there's some normal attrition. We found that in our UCL study that I showed you earlier with ultrasound. Some of the players were no longer in the system. It was actually, I had a bunch of pushback from the reviewers because they said, well, your rate of follow-up was low. And I said, well, these players aren't even in the system anymore. I mean, I can't go find them wherever they are. They're not part of the Angel system anymore. So rate of return to play has to be the same. To consider yourself a success, rate of return to play has to be the same between controls and whatever surgery you did that were matched by draft year, so they're the same age. And it has to be the same as it was pre-op. So you have to be able to say, I'm at least as good of a player as I was before surgery, and at least as good of a player after surgery as I was, as the other guys that are in the same cohort as me. And then we also had to pick 4 variables that we thought were the most important. And these are the 4 we settled on. Number 1 is win-loss percentage. Did you contribute to your team winning baseball games? For pitchers, we looked at walks and hits per innings pitched. So how effective were your pitches? your fielding independent of your pitching. And then lastly, and the one this is, I think, we consider the most important, I think most people consider important, your wings above replacement pitcher or player, your WARP. These 4 variables we consider to be the most important of all the performance variables. So I'm going to turn it over to Brandon. Brandon's going to talk to you about a bunch of the return to play studies we've done. But I want you to think about this whenever someone presents return to play, whenever someone gets in front of you and says, I have 90% success, I would ask you to get up and say, what do you mean by that? And if that's greater than 0 pitches and greater than 0 games, that's not a number you care about. You need to care about this number. Is the performance the same? Is the rate of return to play the same as match control players? And if it's the same, then you can say that's a success. All right, thank you.
Okay, am I on? Yeah, just one real quick question, just on how you presented that last paper. The match draft, you matched first rounders with first rounders, 10th rounders with 10th rounders. Is that how you matched them in regards to the draft?
As best as we were able. There's obviously some limitations in the number of available control pitchers, but that was the goal, yeah.
Yeah, because people have done it at different draft levels, also have done it on signing bonuses, because some guys get moved up or moved back based on signing bonuses. So that, that also is a thing. I just want to let you answer that question. Okay.
Yeah, absolutely.
Brandon's going to go over the surgeries and return to plays. Try to take as many notes on this. This is a great presentation. Okay.
Don't worry, the slides will be available for you guys. You don't have to worry about taking too many notes. All right, so here we go. So that presentation that Pete just gave you is so important to understand, because when somebody talks to you about getting back is different for everyone, but everybody wants to get back to the same level, and you have to properly counsel these patients, players, coaches, their family members before operating on them, and give them some good information. Now, a lot of the information I'll show you today, Pete and I have done together. Actually, Stan has a really good paper out that talks about the overall injury incidence in Major League Baseball over the last several years. He did that study with Chris Camp, and it kind of gives you an idea of what the injury breakdown in Major League Baseball has been, and actually a really helpful paper for you to know what injuries to expect in your players. So, same disclosures. So what I want to talk to you just briefly about is the HITS database, because this is the foundation for all the research we've done. And what the HITS database is, it's called the Health Injury and Tracking System database. It's maintained by Major League Baseball. And it's basically a centralized electronic medical record, and it has de-identified player information that was developed kind of as a league-wide surveillance system back in 2010 to keep track of player injuries and disability time. And so the data is put into this by the athletic trainers for each team. And this takes a tremendous amount of time and effort and diligence. And quite frankly, it's only because of the athletic trainers. And I know some of you are on this call, and I just want to say how grateful Peter and myself and all of us that do baseball research are, because it's only because of the time that you put in that we're able to extract this data and then provide you with some good information that hopefully is useful to you that you can use. But without you guys doing this, we wouldn't be able to do it. So we're very grateful for that. The other people that we have to really thank are on the Major League Baseball side: Kevin Ma, Dana Rowe, John D'Angelo, Lindsay, and many others that also help us to get the data from the HITS database, because the HITS database has the players de-identified, right? So when we get data, we don't know the players' names, right? Because that would be violating their rights and things like that. We have to get IRB approval. So we don't ever look at their names. They have kind of a player number assigned to them, and then Kevin, Dana, and John have to go get the performance data associated with them so that they can give us that as one chunk, so that we don't know who's who in any of these studies that we're doing. It takes a lot of effort, so we're very grateful for that. Some of the studies that Stan, Peter, and myself have done over the last years to look at return to sport following injuries, you can kind of see here. And I'll go over a couple of these in the next 10 or 15 minutes or so. I don't want to talk about the purpose of every single study individually, so I want to just kind of give you the general purpose of all these studies. So the central purpose of these is really to kind of report the rate of return to sport in professional baseball players following a specific injury or a specific surgery. And then we wanted to look at the difference in performance between pre-injury levels and when they got back to return to sport. And as Pete said about these match controls, what we then wanted to do was look at the difference in return to sport rate and performance between our cases, being the players that had the injury or surgery, versus a set of match controls. Because we want to know, as Peter said, performance is going to decline with time. So we want to know, are these players who had a surgery, is their performance declining because of the surgery, or is it declining because that's just the normal decline that we see in our pitchers as they get older? You just don't see the Tom Brady of pitchers out there right now. Although his game last week, not so good. So from a methods perspective, I went over the HITS database with you. We always include all the professional baseball players that had a specific injury over a specific time period. Usually it's 2011 to 16, 17, 18, depending how long of a follow-up we want, okay? And then I would usually go through some of the MRI reports that have been de-identified, or MRI images that have been de-identified, to basically make sure that a player had the injury that they said they had, right? So for the lat tears, for example, wanted to see the MRIs to make sure they actually had a lat tear and not something else that they were called a lat tear for. And then we kind of deemed a player to have returned to sport if they got back to playing after surgery, and then we broke it down into the same level or higher, lower level, or of course not getting back at all. And for the majority of these studies, we usually use a minimum 2-year follow-up. Some of the meniscectomy studies, we did a little bit less because they can get back sooner. And then, of course, we looked at in-game performance variables kind of as an average over their pre-injury and post-injury time periods. And then we matched the controls of these players based on age, level of play, and performance, because you don't want to have controls that are really bad and then match our stud players that had a Tommy John back to these controls, because they're going to look great. So you have to match them to somebody who had a similar performance to them before their injury, so that you can see what the natural decline in performance would be afterwards. If you match them to players who are much better or much worse, it kind of throws off the results a lot from the control perspective. So I'm talking now about a couple of specific studies. So meniscectomy, there are a couple of these that haven't been published, a couple of them have. We looked at players that had a meniscectomy, so going into a knee, kind of getting a cleanup surgery, taking care of a meniscal tear. We found that the majority of these guys, kind of average age in the 20s, even split between medial and lateral, so inside and outside meniscectomies. You can see the breakdown of players here. The majority were pitchers. We saw a return to sport rate of 80%, but again, that same or higher level was at 76%, and 4% got back to a lower level. And what we saw was actually 47% of these players actually got back to playing in the same season. Now, of course, that's skewed, right? If you had a meniscectomy in April, you're more likely to get back that season than if you had a meniscectomy in September. Chances are you're not going to get back from that. And when we looked at kind of full time to return to competition, you're looking at about 160 days, with a pretty big variation there in guys getting back. And of course, when we look at these studies and we look at time to get back, see, where you are in the season is a big issue for this, right? Because if you get hurt in, let's say, June, and you didn't get back before the end of the season, well, by the time you got back to full competition, you already had to undergo the offseason, so it skews the data just a little bit. For this one, we didn't see any difference in return to sport rate or timing of return to sport between, medial or lateral meniscectomies. We saw pitchers had a little bit of decrease in usage after they got back, but actually their performance was very good. Their wins above replacement, fielding, independent pitching was very good afterwards. And hitters actually saw a decrease in usage as well, but their efficiency went up. So their wins above replacement went up. And these sabermetric variables have been very beneficial for us, because a lot of times we get a lot of data, and it's difficult for Peter and I to kind of pick out what we think is relevant, because what we think is relevant may not be the same as what you think is relevant. And so sometimes we try to report it all, and it becomes a lot of data to report, and we want to make it easier to digest. So we've been trying to figure out what the proper performance metrics are to report in these studies. We tend to think these sabermetrics variables are a little bit better than something as simple as, home runs given up in a year, because that obviously varies by number of games played, et cetera. So we'll continue to work on this over years so that we can kind of drill down and give you a better idea, rather than a huge table of data. Try to give you some succinct explanation on what we think from a performance perspective. So meniscal repair, now this is when, of course, you fix the meniscus rather than just take it out. So you have to give the meniscus time to heal. Much fewer players, only 31 of these players over the time course we included them in. Similar breakdown to what we saw in the meniscectomy group. Interesting in this one, from a meniscectomy perspective, a lot of times these players don't necessarily fail a meniscectomy. Sometimes you need a revision knee scope down the road, but they don't usually need one relatively soon after. A meniscal repair, sometimes these don't heal. And so about a quarter of the players that had a meniscal repair, it didn't heal, and they needed a meniscectomy within 2 years of having their initial surgery, which is pretty interesting to know. So there is that risk that they're going to have a revision surgery if they have a meniscal repair. What we found in these guys was 74% return to sport rate, but only 68% got back to the same or higher level. So lower than the meniscectomy group. This is a little bit bigger of a surgery. And we saw was the time missed was a little bit higher. So they missed an average of 187 days versus the meniscectomy group, which was lower. The time to return to sport at full competitive play was about 209, so a little longer than getting back to just playing at all. When you look at return to sport rate again versus medial lateral meniscectomy, didn't really see a difference. And then from a performance perspective, same thing, a little bit of a decrease in utilization, but most of the performance metrics were unchanged from after surgery. When we look at ACL reconstruction, we found about 125 players that had an ACL reconstruction. And I should mention, the majority of players that have these surgeries are minor league players, okay? Because there's obviously a whole lot more minor league players than there are major league players. And so a lot of these studies, you'll see somewhere between 60 and 80% or even more of the players are from the minor leagues. And so just keep that in mind when you're looking at these studies. We don't usually separate out the major league players because the numbers are slightly lower and it'd be harder to find statistically significant differences. So we generally have them lumped together, but just keep in mind that these are majority minor league players in most of these studies. From an ACL reconstruction perspective, again, an 80% return to sport rate, but 73% to the same or higher level. So that's 7%. I mean, that's relevant. You fall into that 7% that you don't get back to the same level. That's unfortunate. It's, a little less than a year to get back for these guys, similar to what it is in most sports. And I'll just mention, the most common graft choice for this, because of course we're recreating a graft, is a BTB graft, a bone patellar tendon bone graft. And there were a lot of other concomitant surgeries that happened at the same time with these players. And we didn't really see much of a difference in performance metrics, pre or post ACL in these players, which is great. When we compared them to the controls, we didn't really see much in the way of a difference here, which is excellent. And similarly, based on drilling techniques and graft types, things like that, we didn't see much of a difference. So important to know that from an ACL perspective, guys usually get back and do pretty well. We get a lot of questions about lat teres injuries because these are something that's come on recently, and Peter, myself, Stan, Dr. Romeo have seen a lot of these players recently. And what we found, we looked at the Major League data set, was about 120 pitchers had a lat and teres tear between 2011 and 2016. Most of them were treated non-operatively, appropriately, almost 90%, and just over 10% were treated with surgical repair. And you can see the time from injury to surgery was pretty significant because this is a hard thing to diagnose sometimes. You have to get an MRI of the chest wall to diagnose a lat teres tear. And if you don't get that and you just get an MRI of the shoulder, you may not actually see the lat teres tear depending on what their field of view is. So you can sometimes miss this, and it's a hard thing to diagnose on physical exam. If you look at the guys treated with surgery and without surgery, their return to sport rate was identical. So 75% on both sides, okay? Certainly the guys treated without surgery got back faster than the guys with surgery, as you'd expect, more than twice as quickly. But when you look at some of the performance metrics, what we actually saw was that pitchers treated non-operatively saw a significant decline in their whip when they got back. Pitchers who were treated with surgery actually did not see a decline in any of their performance metrics. So this gets back to, yes, players were able to get back to playing at the same percentage, but from a performance perspective, actually the guys who had surgery did better. Now they had a longer time off to rest and recover, so that may play a hand in it, but they actually did a little better when they were able to get back. You can see here, this is just a summary of that. Now, ulnar nerve transposition is something that we talked about a little bit, and these are just some images here of what it looks like when you're dissecting out the ulnar nerve, and that kind of little thing here is around the ulnar nerve. This structure here is the ulnar nerve that runs around the back of the elbow, kind of right in the medial epicondyles here. Your UCL or Tommy John ligament lives over here. And sometimes this causes guys nerve symptoms, so we have to do something called a transposition, where we move that nerve in front of the medial epicondyle here, the so-called anterior subcutaneous transposition. You've probably seen that on operative reports before. Not a super common surgery. About 50 players had this over the course of since the HITS database has been installed. Majority were pitchers. Now, an interesting thing with this is 14 of these players actually had a prior Tommy John surgery. And the reason that's relevant is because there are some of us who only transpose the ulnar nerve if it's symptomatic when we're doing Tommy Johns, and there's other people who would transpose it routinely. Now, there's no right answer to this. You can do it either way, and the people who do it all the time say, I saved 14 people surgery here, and the people like me who transpose it only if they're symptomatic say, okay, but we probably didn't need to do it on the other, 52 or 38 people, but did it cause a problem? Probably not. So it's kind of up for debate what to do. What we found was here that actually 62% of players got back to returning to sport, and only 56% got back to the same or higher level. When they got back, their performance was fine. So if they were able to get back to the same level, they did very well, but but getting back to the same level was actually more difficult than we would have thought with the surgery. And when you look at comparing them to a match control rate, they didn't really see any differences with the exception of the cases let up more walks per 9 innings, so nothing really significant for them. Now, the thing I'll mention is here is that when players had a Tommy John surgery before the ulnar nerve transposition, and we compared them to controls that had a history of a Tommy John but did not need this ulnar nerve transposition, we found no difference in performance metrics or return to sport rates when you compared those two groups. So it's important to note that, okay, they didn't have their nerve transposed the first time when they had their Tommy John. They had to have it transposed later. They did just as fine as the guys that had it transposed initially without any subsequent symptoms, and getting back to sport was not a problem. So that's an important thing to note, that maybe we don't need to do this all the time. But again, maybe you should do it in everybody. We're not really sure yet. Now, just talk briefly on UCL, then we can get to some questions. We get some questions a lot of times. Should you harvest hamstring? Should you use a palmaris? Does it make a difference? Well, we tried to look at this, and not specifically look at it in ability to return to sport, but potentially in future injury down the road, okay? So what we found was 195 players had a UCL with a hamstring autograft, and we compared this to 195 players that had a UCL with a palmaris autograft. And we found no difference in return to sport rate or timing of return to sport between the two groups, so they did exactly the same, okay? However, the guys that had a hamstring graft taken, they were more likely to have a lower extremity injury down the road than guys that had a palmaris taken. Similarly, guys that had a palmaris taken were more likely to have an upper extremity injury down the road than guys that had the hamstring graft taken. So it gets back to that old saying of there's no free lunch. Well, there's no free lunch here, because if you take the hamstring, they're more likely to have a lower extremity injury down the road. If you take the palmaris, they're more likely to have an upper extremity injury. Again, performance didn't make a difference. We saw a little bit of a decline in the players' performance when they got back in both groups. But when you compare the groups between each other, it didn't seem to make a difference. And the other question we'll get is an ipsilateral versus a contralateral hamstring graft, right? Because if you're doing an ACL reconstruction, you're going to take the hamstring on the knee that you're operating on. It's common sense. You're right there. You're already making a decision. Well, in a Tommy John surgery, you're operating on the elbow. So you can take the graft from either leg. It doesn't matter. And so we tried to figure out, does it matter which leg you take it from? And based on these results here, the majority of MLB physicians, and we've actually surveyed them, they take it from the landing leg, so the contralateral side, okay? But there was no difference in return to sport rate or timing of return to sport, subsequent injury to the lower extremities, subsequent hamstring injuries, upper or lower extremity injuries. So it really, from an injury perspective and performance perspective, doesn't seem to matter which leg you take it from. We did do a study looking at EMG analysis of this, and we found that the hamstrings from the drive leg were a little more active during the pitching motion in our adolescent group that we performed the study on. So it kind of led credence to what most of the Major League Baseball physicians have been doing and taking it from the landing leg. But again, from an injury perspective, it doesn't matter. There's, of course, limitations to these studies. You can't look through all the notes of all these players. So sometimes we're going to miss some of the players. Sometimes things will be included that shouldn't have been included. And of course, there's sometimes that we're going to miss players that should have been included. But overall, it's a very good data set. So this is just for your reference of players getting back to the same level. And if you look at this, the take-home point I'll tell you, and I didn't talk much about the shoulder, but players do well for lower extremity injuries. Pitchers who have shoulder surgery do not do well. They're getting back at 30 to 50% based on the type of shoulder surgery. It's not great. The rates are on there, and you can take a look at some of the studies we have. You'll see what I'm talking about, but it's not ideal. So we try to manage these guys non-operatively as best we can. And we still have some room for improvement in elbow surgery. Last thing I'll say is there's another baseball meeting that Dr. Romeo and Dr. Ahmad put on in next week. I think Peter and I are both going to be on that as well. And it's another good thing to, for those of us that are just interested in baseball, if you have any interest in that. So thank you. These are some pictures that, Stan mentioned before when we went out to Japan. Dr. Sugaya, who's absolutely fantastic, and had us out there for a conference, and just the hospitality of everyone out there, and the experience was fantastic. So very appreciative of him for that. All right.
Great. A lot of information. All these articles that they've quoted, other than the ones that they haven't finished, are on that bibliography we sent out to you. So they do have, just so you guys know, they have, I think, 26 references from this particular topic from you, not from other people, just from your stuff. We got so many questions. It's kind of, I want to get back to the audience. And I think a lot of people want to get more information on this stuff. We have about 30 minutes on the Q&A. So Nancy, why don't we go ahead and get some of the people. Most of these are some of the questions that have been left over from last time, but they all relate to all the presentations.
Okay. How much of the weighted balls or lighter balls is due to the Hawthorne effect? Very hard to do double-blind study with different weighted balls.
This is Dr. Gary Green's question. So, yeah, remember, he actually approves all the research that you guys do. So I'd be very careful with this one.
Yeah.
Only kidding.
So Brandon, do you want me to start talking while you Google what the Hawthorne effect
I just
is?
Googled it while you were doing that. I had to look up Hawthorne effect. Gary, come on with this. So what Google says what the Hawthorne effect is the alteration of behavior by the subjects of a study due to their awareness of being observed. And he's absolutely right. I actually didn't know what that was called, but I know of this saying. It's a very interesting thing. When you do a study that's randomized and they don't know, you kind of eliminate this. When you do most of the work that we're doing, certainly the prospective ones, a lot of the guys know what's going on. Now, in the lighter baseball study that we did, it was only a lighter baseball group. So there was no group to compare it to, which is a negative for the study, but it actually, I think, may not be as relevant for the Hawthorne effect that you said. I will say that sometimes guys don't want to tell you they got injured, so that's absolutely true. They feel like they're part of a study. They want the study to work. They want to show that what you're doing is right because they don't want to be the person to ruin the study. So that's definitely something to think about. It's something to mention for sure, but I don't know of a good way to mitigate that in the types of studies that we do.
Peter, do you have anything to comment on that?
He's still looking.
He's still looking. Okay, that's okay.
I agree with what Brandon said. I mean, I think it's a challenge. I think that weakness is mitigated by the fact that there's no control group, which also makes the findings of the study harder to interpret because it's hard to know if you just put the players through the same program with normal weight balls if they would have come to the same advancement in velocity. So that's definitely a downside. I think that that's the effect, the overall limitation that you mentioned is a really important one for research in general. And I will tell you that there's research is hard, and you'll see this. If the more you dive into it, the more you realize that that it's very challenging to control all of the various confounding factors that may bias your results. And if you don't try and search them out, there's one that can get you without you even knowing about it. And velocity, I think, is a good example of this because there's a lot of studies that were conducted before we described this connection between velocity and injury that did not include that variable. And it's hard to know if some of the early studies that looked at risk factors for injury may just have been describing secondary correlates with injury. I think breaking balls are a good example. So if you look at youth pitchers, the kid that gets taught the curveball is the one that's got a higher velocity fastball. So I think that a lot of our early findings may have been, so to speak, confusing umbrellas as the cause of rain instead of the clouds up above.
Yeah, I think that's also true when you look at velocity related to Tommy John surgeries. Many, many years ago, when you guys are still in college, there was a lot of talk on Tommy John, especially from the media, that you do a Tommy John surgery and you come back throwing harder than you threw before. So this is a way the methodology has to be set up perfectly. What we saw actually when we first started looking at it, that the velocity actually went down. But then when they started doing age matched, because it takes a year and a half, sometimes longer, to get back, now you have an older player and he goes into a different bucket, if you will, in regards to the decrease in velocity by age. So he fit his age group, but if you compare it to when he started, his velocity may have been more, and they found out the velocities are about the same as they come back. Comments on that particular issue?
That's the exact problem we described earlier. I mean, I totally agree with the way that you described exactly how that problem plays out.
Yep, I 100% same page.
Yeah. Okay, I have just one real question on I thought your summary of all your return to play criteria at the end was really good. I was a little fascinated by the olecranon open reduction interval fixation, 68%, which seemed a little bit low to me. We seem to be seeing more of that, or we're getting more of that in regards to doing that. Any comments on why you think that's happening, and what are you thinking about the 68% return? We're still seeing that a lot in adolescents and college.
Yeah, and I think that, you have to take these results for what they are. These are professional players that have had a lot of miles on their elbow. And so when they're getting olecranon, either acute olecranon fractures, which a minority of them were, or olecranon stress fractures, which was a majority, you have to look at what else is happening in their elbow at the same time. Similar to the ulnar nerve transposition study. These are guys that have had a ton of mileage on their elbow. So yes, they have an olecranon stress reaction. Yes, you're going to fix that in whatever way you choose, tension bands, screws, etc. But they also have other things going on. Is there a small component of the lax UCL with some valgus extension overload that's causing them to have this stress reaction? With the ulnar transposition, do they have a UCL issue going on? And this is just a simpler surgery to try to alleviate some of their problems and try to get them to come back. Those are some of the things that I tend to think about in these players. So I do think that our results in younger players would be slightly better if we had a way to kind of combine the results that we have for the younger folks in a way that we do for Major League Baseball. But Pete, I don't know, what do you think?
Yeah, I mean, I just completely agree with you that it's really hard with younger players, especially because, and this is really important, there's so much more variability in ability and potential among youth and adolescent throwers. There's so much more variability in mechanics that although that group is, I think, super important from a public health perspective, it's very challenging to know how we can really compare apples to apples in those players.
I think the other thing is you just don't have enough data, especially at the high school level. The HITS data opened our eyes to all these things. Again, you guys were young in 2010 when we had no HITS data. We knew nothing about things. It was all individual institutions that were reporting their data, like ASMI and that kind of stuff. Now we have a lot of good information at the professional level. We still have pretty poor data on the minor leagues. I mean, on the high schools. So,
one of the, Stan, can I say one follow-up thing to that comment? Because I think it's really, what you just said, I think is really important. One of the reasons why I think this research is important is because it's unbiased as to the data. So it comes from Major League Baseball. It doesn't come from one surgeon trying to say, clearly based on this paper, I'm better at this than everyone else. One of the things we've done recently that really showed that is we looked at PRP. So platelet plasma has been touted as, potentially the UCL reconstruction killer. Maybe you could just give them all PRP injections and it would heal. And there are papers of people showing like 95% success rates. So we tried to look at that, and that paper is not in the group that we presented, but we looked at rates of return to play for non-operative treatment of UCL injuries, comparing PRP to no PRP, and they were no different. So that would suggest that there actually is no benefit to PRP. And I think that's partially because you have this unbiased data source. Now, it also may be because the data source is much larger and there's more heterogeneity. But again, I think that's one of the reasons why it's so important we do this kind of work to really understand what's happening.
Yeah, I think there's an article that was published out of MLB. It was sort of a preliminary study on PRP. I think Christopher Camp and Mike Zuccotti put that together a couple of years ago, looking at how people turned out with PRP versus just rehab, and it was rehab did better. Let's first of all, we got several questions on when your books are coming out. When are they going to be out for publication? So we've got a couple of those. Could you answer that question?
Yeah, the elbow book is in the copy editing stage now, so I'm almost done with that. I would say probably in the next 7 months, the elbow book should be out. The biceps book's a little bit behind that, so that'll probably be more like mid to end of next year. That'll be out. You can see quite a few chapters written by Dr. Chalmers in both of those books.
Great. Nancy, let's have some more from the audience.
Okay. Beyond the fact that a fastball is typically thrown harder than a breaking ball, does a slider tend to place more stress on the elbow than a fastball? It seems that the more hard breaking balls are thrown, there seems to be more injuries. Is that true, or is it a fallacy?
I think our current evidence would suggest that that's a fallacy. The slider has been traditionally thought to be a really dangerous pitch. It's not clear if that's true about, there are some kind of mixed breaking ball fastball, like the cut fastball, like the Mario Rivera pitch, that is a breaking ball in some ways, but that probably puts just as much stress on the elbow as a traditional fastball. There's also, of course, like the two-seam, four-seam, that probably is equivalent. But some of that stuff has not been as extensively studied. The motion analysis studies you need to do to prove that are actually really expensive to do, which is the reason why there's maybe a dearth of knowledge about some of that.
Yeah, no, I agree with what Pete said. I don't really have much to add to that. It's interesting because you'll hear a lot of guys talk about their experience with certain players. Chris Sale, for example, about his breaking pitches and wanting to hold him back because of elbow issues, things like that in the past. But that doesn't play out when you look at a lot of things. So I think that's something we still probably have to work out.
Difference between a large sample size and anecdotal information, which we see a lot in baseball.
Yeah.
Nancy?
Okay. What do you think is the impact of variability of individual preparation or warm-up routines in being able to properly assess workload?
I think that this gets back to the individualized talk, like we mentioned. So I don't think there's a right way to warm up. I think guys warm up however they choose, and I don't think you should put a limit on the number of throws that they're doing when they're warming up or how they do that. I think you should let them warm up however they want, but I think you have to keep track of that as they're doing it. And I think, to Stan's point, you can't just rely on a pitching coach or the player to tell you how many pitches they threw. You probably have to actively monitor that with either video or somebody standing there keeping track of the pitches. I think that it has to play a role in the workload that you're going to call their workload for that game. That would just be what I'd say. I think it has to play a role in their workload for the game. And I think, again, those pitches should probably count for count less than a game pitch, but I don't know how much of a percentage less, because Stan's point, they may think that they're throwing at 50% effort, but they may actually be throwing at 80% effort based on the gun, or vice versa. So it's hard to know. And you may have to take that into account when you're looking at it too.
I think you're absolutely right in regards to the individualization of workloads, and based on age, what they're doing, starting pitcher versus relieving pitcher, all those kinds of things. And I think Elytras wrote this article in his group out there, looking at number of pitches, that it took depend on individual in regards to revisions of UCL revisions. So I think that you gotta get down and dirty all the way down to the bottom of that particular individual if you're going to put a risk factor on that particular person. So then the question is, with all this data, especially on the UCL, do you draft a pitcher who's a junior or senior in college who needs Tommy John surgery, and what's your risk factor there? I'll ask you that question.
Yeah, Pete, take it.
Yeah, I mean, we've had this question a ton of times about what is if you have an ulnar ligament reconstruction, what is the risk to the future of your career? Certainly, I think there's a couple of different scenarios, so I'll try and play all of them out. One is the player who's undergone a UCL, come back successfully. Is that player a risk in the future? I think the answer probably is no. I think the second player is the player who has a questionable ligament. And there's a study we haven't mentioned tonight, but that Brandon and I did, that I think plays a role in this. So we looked at every MRI of every, I think was the first 2 rounds, Brandon? It's the first couple of rounds drafted pitcher over the course of like 5 years.
Yeah, the top 50.
It was hundreds of MRIs. We looked at hundreds and hundreds of MRIs. And there are things you see regularly in healthy pitchers' elbows. Like you'll see a little bit of edema around the ligament. You'll definitely see a little bit of edema in the bone. You will not see a full thickness UCL tear. So if you see a full thickness UCL tear, I think the answer is that player is an abnormality, and that player does not fall into they'll probably be fine category. So the player that needs a UCL tear, I think, is a little bit of a risk. As I showed you in the numbers earlier, the rates of return to play after that procedure are not 90%, especially if you consider that most of the players being drafted are going to try and be pushing up through a bunch of layers to get where they want to go at the show.
I want to ask you this question. It's not related to this thing, but I think while we have you here, I think the audience want to hear. In 15 seconds or less, tell me repair versus reconstruction, when, where, and how.
Yeah.
Maybe not how, just where and when.
So I think repair has been great. To give you some history on it, obviously very briefly, talked about a long time ago by Dr. Conway and Dr. Jobe when they initially mentioned reconstruction. It did very poorly. It's kind of undergone a lot of revisions since then. And so Buddy Savoie put out a great paper in 2008 that said really great return to sport rates, mostly in gymnasts and younger players that had a UCL repair. And then Jeff Dugas, out of Alabama's group with Glenn, put out a paper recently that showed his first 100 UCL repairs with an internal brace augmentation. An internal brace is a very thick, high tensile suture that you basically run along the course of the ligament and anchor it in two spots to act as a backstop to the ligament. For me personally, somebody who has a healthy ligament has a tear either off the medial epicondyle or distally, right? So it can't be a mid-substance tear. It's got to be either where it starts or where it ends, and has good quality tissue. So the 32-year-old Major League Baseball player that's been throwing forever and has a very degenerative ligament that then pops his ligament, I don't think he's a good candidate. The 18-year-old pitcher that I saw 6 weeks ago that had a complete full thickness proximal UCL tear, he was a great candidate for this because their rehab is better. You know, Kevin Wilkes done a great job explaining to us how to rehab these. And for any of you that are interested, I always recommend looking at Kevin's stuff because he details everything fantastically. You're looking at almost 7-ish months from a repair versus 12 to 24 months from a reconstruction. So if it's possible, the repair is a great option, but you can't try to do repairs on players whose tissue is not great because you will not get good results with that. And we haven't really seen the repair done in our high-level athletes yet. High school, college for sure, but there's not a lot of repairs that have been done in Major League Baseball players yet, so we don't know what the results are.
Yeah, I would echo everything Brandon said. I think the results of repair in youth and adolescent and college players are great. They're published with Dugas. Paletta has a series with very good return to play rates. My own personal experience has been very good with that procedure. I think Brandon's has as well. So we do that procedure. It really does work for the right player. I would add that you do need to warn every pitcher. I warn every pitcher I do it on. I'm going to look at the tissue. If the tissue doesn't look good enough, we're going to do the right thing for your elbow, do the reconstruction. And I have a fair number of players that come in with a very small or thin ligament that tears. And to me, I worry about the repair there. Probably the group of people that we see here that probably no one else sees, and what's one group that's given me a unique perspective here is I have a group of pitchers that are Mormon. Myself not Mormon, but group pitchers that are Mormon. They're phenomenal pitchers through high school. They pitch 1 year in college. They go away for 2 years and they don't play at all. Then they come back 2 years bigger, 2 years heavier, and they start throwing again. And many of them immediately tear the UCLs because all of a sudden their velocity's bumped a couple of miles per hour. Their ligament has seen no load for 2 years. And now it tears. And for me, that player is not a repair, even if the tissue looks like it's just a avulse on one side, because the underlying problem is that there's not enough tissue. So I would add that in, and I think that matches with everything that we've learned about the ligament and the way that it adapts.
Right. Yeah. Let's have another question from the audience, and we're going to have to wrap up here. We're almost out of time.
Okay. Let's go with.
How about Regan Wong's?
Okay. Let's see. He said, under hidden pitches, we should also factor in the plyo-care weighted ball training pitchers also complete in addition to their dry humps pitches in between innings, etc. I think it's more of a comment.
Yeah, but I think that he's asking, if you're doing both, what do you do in workload?
Yeah, from an arm care and warm up and honestly a cool down perspective, I agree with you. You probably have to take that into consideration. The other thing that you may have to consider is, okay, the guys who do arm care afterwards or do certain things afterwards, do we factor that in as a positive for workload or as a negative for workload? And again, I don't know the answer to that, but something that we may need to when the 600 or 700 of us on this call decide how to define workload with a formula, may have to put that into the formula. And I agree, it's a good point.
Yeah, I think in the weighted balls too, It does depend on who you're talking about in regards to that. I know I said that before, but I think that makes a difference. I guess we have one more question. Nancy, I think we literally have 60 questions here, so we'll be trying to pick ones that are duplicates.
Yeah, let's see, there's a question here. In most other sports, they use an acute workload relative to chronic load, where the ramp rate should be between 0.8 and 1.3. Is that a consideration with pitchers, or do you simply use a max workload?
Pete, do you want to talk about the studies that we're doing versus acute versus chronic workload?
Yeah, I think it is a factor. I'm not sure that we got into the weeds quite this much with the workload studies, because none of them, to be honest, have been published yet. But we've looked at this exact factor for, I think at this point, 7 or 8 injuries, a huge variety of injuries, to try and understand what happens when you compare the 2 weeks, the 6 weeks, the 12 weeks before injury to that player's baseline, by which I mean everything before 12 weeks before the injury. And what we found is that it matters. It matters for UCL reconstructions. Those players in particular that had a UCL tear had more workload in the 2 and 6 weeks before injury as compared to the player to what they were doing 3 months before. And to me, that really tells us that the ligament that backs up, I think, what we've been saying already, which is that the tissue, your body can adapt. The human body is incredible. It has an incredible capacity to adapt, but it needs time. It takes time for your cells, the mechanoreceptors in your tendons and ligaments and bones, to see that stress, and then they have to change over all of their paracrine and endocrine signaling, and then there's a whole cascade of transcription factors. It's complicated, and that stuff doesn't happen immediately. And then it, of course, takes in bringing in new tissue, building new cells, building more collagen, building more hydroxyapatite. So that's what I would say. What do you think, Brandon?
No, I completely agree with that. And I probably should have gotten into this with the studies, but I wanted to keep us on time. Because looking at acute versus chronic changes, similar to that study that was done before, looking at how the ERA changes as a cumulative effect of their workload. I completely agree with Peter. I think that if somebody is used to throwing a certain number of pitches or facing a certain number of batters or working on a certain number of days rest, and they've been consistent with that throughout their career for a long time, and then you change that acutely, whether it's 2 weeks, 6 weeks, and not over the course of the season, I think you're opening them up to injury. And it's not just UCL injury. It's like Peter said, it's hamstring injuries, it's oblique strains. So we always talk about UCL, but there's a lot of other things that knock guys down for a long time, internal impingement, et cetera. And we've basically seen that in most of our studies, that if you change their general workload, so what a guy's been doing for years of his career, and you change it acutely and try to ramp him up very quickly for something, we've seen a significant increase in injuries when you start to increase the workload acutely. So I don't know what the right ramp up would be or what the right lead up would be, and it's probably based on what their workload has been before. So it's probably a percentage of what their workload is, how quickly you can ramp them up, but it's definitely a factor you have to consider.
Well, then would you recommend at some point a mathematical formula that alerts you before the 6 weeks comes, that between 2 and 6 weeks where they're increasing their workloads, and you're able to put the workloads in and be able to see when the acute is much bigger than the chronic, and you're heading for a cliff? It seems like you should be able to do that. Maybe when we ever get into the use of AI and putting all the data in, I wonder if you get to a point where at 3 weeks you say, this guy needs to rest. Let's don't wait till he falls down. Let's do something before. What's also interesting to me is that the sabermetric people for years and years and years looked at performance and decreased performance to try to change the game, meaning starters don't go farther, they don't go into the third rotation, all those kinds of things, because the performance metrics said they did poorly. Wonder if there's the other alert that says it's time to back down. Thought.
Yeah, no, I think that's completely accurate. And you're right. We should be able to figure out when they're getting above a certain change in their chronic workload, we need to probably back them down. And again, there's going to be some guys that can tolerate it and some guys that can't. The problem is we don't know who can tolerate it and who can't. So you don't want to overstress the guys, because then you run the risk of them breaking down.
Yeah, I mean, I think that's the real difficulty of what you're talking about is that if you ask the pitchers, they all think they're Nolan Ryan, you know. They'll all say, well, I'm going to pitch until I'm 45 and I'm never going to get injured. And you and I have talked about this before, Stan, that like for the pitcher cares about performance and they don't think about injury. And I think the onus is going to be on the teams and the training staff to try and figure out how we change the culture, but more importantly, from the team's perspective, the injuries are so costly that they're going to have to look more carefully at how do we figure out who's going to get injured before they do get injured.
Yeah, what you just talked about is a whole nother conference. I'll tell you, it's pretty interesting stuff. We're going to have to wrap it up. I wish we had more time for questions. Audience did unbelievable in putting their questions in. This is the most questions we've ever had on a program. Thank you very much for coming in and giving us 2 hours of your expertise in this area. And hope to see you more down the road.
Thanks so much for having us. This is great.
Thanks, Dan.
Okay.
If anybody has any questions that they want answered, you know, you can reach out to Stan. Stan, you can give us, I'm sure Pete's fine with it. You can give our emails out.
Absolutely.
Talk about this stuff.
Absolutely. Yeah, absolutely happy to help. Always.
Okay. All right, great. We're going to keep the conference going so you can do the survey, which please do your email correctly so we can get the certificates to you. Appreciate everybody who came on, and we will see you actually in January for our next presentation. All right.